Endometriosis is a common, often debilitating gynecological condition that affects approximately 1 in 10 women. Women may get painful periods, pain with sexual intercourse, or pain when opening their bowels, particularly during periods. Some may find it more difficult to fall pregnant. Others have abnormal bleeding. Strangely, some women have no symptoms at all. Typically, symptoms are not present from the start, but get worse over time. Endometriosis is defined by the presence of tissue similar to the lining of the uterus outside the uterus. It is not exactly clear why some women get endometriosis. It is likely that genetic, biological and environmental factors all play a role, but it is believed that central to the development of endometriosis is retrograde menstruation. Every time a woman has a period, the lining of the uterus is shed. Although most blood goes through the cervix and vagina, in up to 90% of women, some blood may flow back into the pelvis through the fallopian tubes. Mixed in with that blood are cells from the lining of the uterus. For most women, this retrograde menstruation has no important consequences, as the immune system will clean up the blood and endometrial cells that arrive in the pelvis. In 1 in 10 women, however, the endometrial cells manage to not only survive, but also implant in the pelvis. No one knows exactly why, but possibilities are that the endometrial cells are more aggressive, or that a decreased immune response makes that the pelvis defends itself less well against implantation of endometrial cells. In any case, endometrial cells find themselves a spot to implant, usually in the deepest part of the pelvis, as that is where gravity takes them. They therefore often implant in the pouch of Douglas, which is the little pouch behind the uterus, or on the back of the vagina, on the bowel, or on the bladder. Once implanted, those endometrial cells start behaving exactly like the lining of the uterus. That means that every time a woman has a period, those little implants will have a mini period as well. And because they bleed, they cause inflammation and therefore pain. Initially, these lesions are very small, almost like a little brown freckle. This is called superficial endometriosis. The lesions can be absolutely everywhere, but because they have no volume, they cannot be seen with ultrasound. The only way to see them is by looking inside the pelvis with a laparoscope. Approximately 1 in 5 women with endometriosis will develop deep endometriosis. The endometriosis cells don't just superficially implant, but they actually infiltrate. When the endometrial cells infiltrate, they form clumps, which are called nodules. It is unclear why this happens. Maybe endometrial cells are even more aggressive, or maybe the pelvis defends itself even less. But because these lesions form clumps and therefore have volume, they can be seen on ultrasound. Endometriosis thrives on periods. Lesions bleed with each period, and with each period, some more blood will flow back through the tubes and more lesions of endometriosis can form. Even after removing it, because women continue to have periods, endometriosis may come back. Because surgery is not a final solution, very often the first approach to possible endometriosis is aimed at having less periods. That will not remove the endometriosis, but it will keep it stable. The Mirena IUD will often stop periods completely, and the pill may allow skipping periods. It is a misconception that the pill or a Mirena masks symptoms. Instead, they actually slow possible endometriosis development down. Doctors cannot tell from symptoms who has superficial and who has deep endometriosis. Strangely enough, the symptoms don't always make sense. Some women have severe pain from small superficial lesions, and other women have no pain or relatively little pain from deep lesions. If a laparoscopy is done and superficial endometriosis is found, it is usually easily removed. If without preoperative warning deep endometriosis is found, it can usually not be removed, as often a bowel surgeon or a bladder surgeon needs to be present. Repeat surgery is then required with a multidisciplinary team. That is why a good ultrasound prior to the laparoscopy is important, as it can give the surgeon warning about the presence of deep endometriosis. The surgery can then be done as a single, well-planned procedure by a well-prepared team, which always leads to better outcomes. It is important to realize as you go for your ultrasound that ultrasound cannot diagnose all forms of endometriosis. The superficial lesions can never be seen on ultrasound, and 80% of endometriosis is superficial. So if your ultrasound is normal, it does not necessarily mean that you don't have endometriosis. You may still have superficial lesions. If symptoms are severe, a laparoscopy should still be considered, with some confidence that if endometriosis is found on laparoscopy, it would be possible to remove it at the same time. If the ultrasound, on the other hand, shows deep endometriosis and you are considering surgery, you need to see an endometriosis specialist, as removal will require more expertise. Because endometriosis may come back until women go into menopause, it is important to choose your battles with surgery wisely. Treatment of endometriosis may involve a combination of lifestyle changes, pain relief, hormonal therapy, pelvic floor physiotherapy, and surgery, and should be viewed as a treatment plan that is mainly aimed at controlling symptoms and improving quality of life.